Evenings, my stomach was hungry, dinner was nowhere at sight, and then suddenly my MA appears right in front of me, looking anxiously. He was pushing a patient seated on a wheelchair, complaining of chest pain. The tone of his voice was so appalling that I decided, though be a junior EP on the floor, I'd rather see this patient myself. The patient says his chest pain started at 6 p.m. and he presented to us at 8 p.m. His pain was compressing in nature, radiating to the lower jaw with a pain score of 9 to 10, and he also complains of shortness of breath, vomiting, and diaphoresis. On further history, he revealed that he's a known case of hypercholesterolemia, on diet control, and it's a chronic smoker, taking 20 cigarettes per day for the last 20 years. He denies taking any medication for any of his conditions, and on presentation, his blood pressure was 132 over 82, heart rate was between 50 to 60s, saturations were 100% under room air, the respiratory rate was about 14. His first ECG upon arrival in yellow zone showed he has suspicious looking ST segment in 2 and 3 with ST depression in 1 and AVL. In view of the presentation and suspicious ECG, patient was immediately uptriaged to resuscitation zone, and the patient was given the normal aspirin 300 milligrams, clopidogrel, fondaparinux, and sublingual GTN. Subsequent ECGs were repeated, had similar findings with no gross evolving changes. A bedside echo revealed inferior wall hypokinesia. Blood was taken for routine investigation and a bedside troponin was ordered for the patient. Patient still complained of pain and morphine was titrated. The first troponin results came in at 11 p.m. was negative. The troponin were repeated again at 1 a.m. Results were still negative. Repeated ECGs at this moment still shows similar changes. In view of the persistent pain, the case was discussed with a cardiologist. The medical specialist discussed this case with a cardiologist, and the cardiologist, based upon the patient's typical history, the echo findings, and the ECG findings, they advised for thrombolysis. So therefore, thrombolysis was undertaken with streptokinase. During this event where it was noted, this patient was hypotensive and not responding to fluid challenge. So the patient required the use of a single inotrop at this moment. Cardiac monitor also revealed multiple ectopic beats, and post-thrombolysis, patients still complain of pain. However, the pain score reduced to 3 to 5. After the thrombolysis, patient was transferred to CCU, where he was again reviewed by the medical specialist. ECG remained the same. Taking into consideration that the patient currently required the use of an inotrop to sustain his blood pressure, a decision was taken to refer him to another cardiology center which was near to our facility. And the cardiologist there agreed for a rescue PCI later in the morning. PCI showed the presence of a large thrombus occluding the right coronary artery. Post-PCI, the patient was pain-free and subsequently discharged home. Looking at the initial presentation and the results of troponin in this patient, questions arise regarding the use of troponin and the false negative results not once but twice in this patient. The first indication of raised troponin in this patient was at 5:16 a.m. This was post-streptokinase administration where troponin I was about 50. This result was obtained from the central lab, which uses a different system. However, I will discuss about the system which is used in our central lab in a later slide. So why is there a reason of discrepancy between these two results? So that's why we need to look at the patient's initial complaint. This patient has a high pre-test probability of coronary artery disease. Pre-test probability of disease should be used to determine the optimal testing strategy. In patients with high pre-test probability of coronary artery disease, routine point of care testing is less likely to yield helpful information. That means you will get a very high false negative results. However, in patients with low pre-test probability of coronary artery disease, routine point of care is also unlikely to yield helpful information. Here you will get a very high positive results. How is this so? This is a diagram of Bayes' theorem to calculate the probability of coronary artery disease. Pre-test probability increases from left to right. And then the post-test probability being tested here is the stress test. The solid dark bar shows negative results, the solid dark bar. And the red bar shows positive results, the red bar. The patient far left has a very low pre-test probability of coronary artery disease, and the patient on the far right has a very high pre-test probability of coronary artery disease. The probability of coronary artery disease increased dramatically when clinical pictures suggest higher pre-test probability. And here, this is the Bayes nomogram. But why are we doing this? We are emergency physicians. We are not mathematicians. We are not statisticians. We don't have time to draw diagrams. We're not going to, when we see a patient, we're not going to draw and calculate what is, how much percentage is this patient. So that's why we have two tools. One is the emergency gut feeling that we had. The gut feeling which I had when I saw the patient and arthritis this patient to resus. And we have clinical decision rules. We have employed various scoring systems in our day-to-day practice. One of it is TIMI, which we all use all the time. We have the gray score, we have the hard score. In this patient, the patient has got a very TIMI score which is very lowish. That means he has got one risk factor, he's got severe angina, and maybe there is some discrepancy in the ECG changes. And all these scores are well validated, but none of them emphasize on the patient's history as part of the score in identification of acute coronary syndrome in the emergency department. But until we have the hard score. Let's see, how does this patient score? This patient's history is highly suspicious. His ECG has got significant ST depressions in AVL. Age is about 45. And it's got one risk factor. That means he's got about 20.3% of major adverse cardiac event in the next 6 weeks. So if you use hard score for this patient, it goes into a very higher range of major adverse cardiac event. Therefore, the clinical judgment plays a huge role for the emergency physician when evaluating chest pain in emergency department. The father of modern medicine, Sir William Osler, once said, "Medicine is a science of uncertainty and the art of probability." I mentioned earlier that the central lab values were the first indicator to show an elevated troponin. Currently, there is no universal adopted 99 percentile value where there is no reference standard for detecting troponin I. Each test manufacturer develops its own assay using different values. Values differ from instrument to instrument. So these are all the various instruments used in the different labs, which we should be familiar. If you see, the troponin levels which are given are not always the same. So sometimes when we refer, we say the patient has got a certain troponin value, but we must also say what is the range of the troponin values in this patient. Different labs use different markers. Additionally, there is no consensus exists on how to define a reference population in terms of age, gender, race, ethnicity, and comorbidity. We do not know, based on certain comorbidities, what will be the troponin levels in certain patients. These results were negative in both the occasion where the point of care testing was used. Point of care is essential in emergency setting to provide a rapid return of information for the clinician. American Heart Association recognizes cardiac markers should be made available to the clinician within 30 to 60 minutes of presentation to ED. However, the main central lab is unable to cope with this. That is why point of care testing is an operational necessity. However, it is important for EPs to understand the limitation of point of care testing. There is a possibility the false negative results in this patient was because the troponin measured was outside the diagnostic window, or maybe the troponin was not sensitive enough. Yes, now we have high sensitivity troponin. We have come to an age where troponin point of care testing has evolved tremendously. We have high sensitivity troponin which can actually measure troponins with very low concentration, 10 to 100 times lower than the currently available commercial troponin. However, with this increased sensitivity comes the cost of reduced specificity for acute coronary syndrome. Patients diagnosed with non-acute ACS can be associated with increased cardiac biomarker testing, telemetry monitoring, and cardiology referrals. This in turn overwhelms the hospital cost and resource utilization. And now we even have ultra-sensitive troponins in the market. False negativity can occur if at all troponins are measured outside the diagnostic window. This was mentioned by Bonner et al. In 1996, but here this is way before high sensitive troponin came into the market. And it has been recently demonstrated that cardiac troponin specific autoantibodies are found in 5 to 20% of individuals. This was in the Journal of Clinical Chemistry in 2003. And it was also mentioned in our journals in 2005, New England Journal of Medicine, and in 2010 by Nosinovich in the Heart Journal. According to him, the release of troponin to the blood can stimulate the production of antibody. These complexes are even present in healthy subjects. The detection of MI in these patients will depend on the reagents used by different manufacturers. So this test might be negative between one reagent and another reagent used. When troponin was a lousy assay, it was a great test, but now it's becoming a great assay. It's getting to be a lousy test. Robert Alges. So the learning points from this: do not rely upon a false negative result in a patient with very high pre-test probability. The presence of low titer of troponin will also give a false negative results. You have to remember there's something called troponin autoantibodies which exist. And even in healthy individuals, it has been postulated that there is always circulating troponin in these individuals. A positive high sensitivity troponin does not mean a patient is having an MI. Thank you.
Okay, thank you. Maybe Prof. Manigan first.
Thank you, and congratulations on your first presentation before such a big audience. We love ultra-sensitive troponins in emergency medicine, right? Because we're looking for a negative. We want to know whether we can send this patient home or not. The cardiologists hate low sensitivity or ultra-sensitivity troponins because they get a lot of false positives. So if we have a negative, we can believe it. That's what the ultra-sensitive troponin tells us. But if it's positive, it means we can't believe it. So we wind up pushing the problem off to our, either to ourselves, because we have to then get a second test, or to our cardiology colleagues. When they love high specificity tests, because they want to know whether this positive is truly a positive or not. So we've gone through this evolution where we are now diagnosing negatives much better than we ever have, but we're diagnosing positives worse. So I think that's a good point to take home from this, and I think it was just a good case to illustrate that.
Okay, yeah, thank you for that presentation. Actually, if you ask me, I think the best thing to do, and probably you also would agree, is just refer the case for a PCI, isn't it? So I hope that will be more readily available for us. Such cases like this where we're not really sure, and it's like 50-50, and you know the risks involved in giving a thrombolytic agent. If you can do a PCI, of course there are risks there too, but at least you can clearly see what's happening. So yes, thank you for presenting this case.
Thank you.
Tadi?
I think this is quite an interesting presentation. I think that we are talking about these topics now. There's a lot of debate, a lot of controversy. That is actually illustrate to us the importance of going back into the basic. Okay? Radiological and biochemical chemistry correlate with the clinical judgment. It becomes what we call it a random, we call it a number generator. So we can make a decision based on this. So I think what we need now is a good, of course, good clinical correlation and based on clinical presentation, plus probably a good radiological or biochemical investigation. Also plus, as you said just now, is scoring the hard score. Okay,
I thought Tadi wanted to say something about echo. No. No. Okay, then, Ananda, thank you very much.
Thank you, Mr. Chairman. Thank you.
Next presentation will be from Tan Tock Seng Hospital, Singapore, presented by Dr. Ochi Harumi. I pronounce it correctly. And the title will be Unusual Presentation and Mimickers of Dengue Fever.
Hi, good morning, distinguished guests. I am Harumi, a medical officer, and today I'm very privileged to be able to share a presentation on our experience of unusual presentations of mimickers of dengue fever. So the original inspiration behind this presentation was that I did emergency medicine as my first posting as a medical officer, and very often we would see patients with fever, myalgia, and thrombocytopenia, and we would often make a clinical impression of dengue fever. Towards the end of my posting, when we reviewed the results, I was often surprised to find that there were a lot more findings when the patient was investigated inpatient. So dengue fever is the most common vector-borne viral illness worldwide. It is a frequent cause of acute febrile illness. Clinical symptoms include fever, maculopapular rashes, arthralgia, myalgia,